Hi, I'm Christy Bird-McKeeve. I'm the Executive Director of Butte-Glenn Medical Society, which is producing these virtual grand rounds. Today is Thursday, August 26th, 2021, and we're really excited about focusing on diabetes, what is the latest in terms of treatments. There's been some significant changes in the last few years. So we will have Dr. Gopinath Sunil of Ampla Health in Chico give that presentation. But first, we're going to have our sponsors and partners, Enloe Medical Center, discuss a little bit of what they're doing in terms of diabetes education with Bailey Martin. So go ahead, Bailey, and share the good news.
Thank you, Christy. We're really excited to hear about what Dr. Sunil has to share. We just wanted to let you know about our pre-diabetes class that we offer. It's completely free and currently it is virtual, so anyone can attend. You don't have to be in the local area. We do it on the third Thursday, the quarter of the year. So we have a little flyer here. It has some information. You can find more information at enloe.org/events. But our upcoming one is on October 21st. And we have our diabetes educator and dietitian, Beth August, do a presentation, and it's super low key. You can ask questions and answers and things like that. So if you have any patients or anyone that you think could use the help, just getting the right information about being a good, healthy lifestyle when it comes to pre-diabetes, we'd love to have them attend. Thank you so much.
Thank you. Dr. Sunil, I know you have some slides to share, and hold on 1 minute. I just realized I have to. Okay, you should be able to share those slides now.
Okay. So what do? I just click on the slides and it'll pop up?
Yeah, and then hit share screen, which should be a green button.
Okay, figure that out. I know you showed it to me last time, but
that was several months ago. And thank you again. The talk about LGBTQ transitions was really informative in the last virtual grand rounds.
Right. Yep, it was fun. So, okay, so can you see that?
Yes, perfect.
Okay, perfect. So thank you again, Christy, and the Medical Society for having me give a talk. This is a subject matter which I hold very close to my heart. And I can safely say that I dedicated about 30 years of my life so far to the study and research on diabetes. And this one is, I'm kind of focusing on diet and diabetes. That's the title of this talk, but it's a recycled talk from one of my previous lectures, but I'll kind of focus on the diabetes updates, sort of where, like Christy mentioned, we had lots of changes happen with the, oops, I think I've lost the screen.
It's still there.
It's still there, okay. Mm-hmm. Okay. All right. So anyway, I cannot see any of you guys. So welcome to this session. So we will discuss briefly about a little bit of a background. So if I'm boring and if I'm talking things over and over again, please feel free to interrupt me and ask me questions or redirect me. So diabetes, let's move on to the next slide. Diabetes, we all know that diabetes is I don't want to call it as a disease. It is a clinical condition where our body gets kind of in a disequilibrium with less amount of insulin, more amount of sugar that can handle. So the body is either not producing enough insulin or the body has lost sensitivity to insulin. That's how we tend to describe that. So I tend to explain like that to patients also, because it is by no means a death sentence. It's by no means a disease to worry about. Yeah, it can do a lot of damage if you're not careful. So we start from there. So insulin is a hormone that is needed to convert sugar, starches, and food into energy. And insulin is produced in the body by the pancreas. So there are two types of diabetes, or probably 3. Some people might try to call it a transition stage between the type 1 and type 2. Type 1 is when the body does not produce any insulin because of any immunological damage to the beta cells, and they simply fizzle out. And then you are becoming totally dependent on insulin. Type 2 is body is not making enough of it or is losing sensitivity to insulin. So despite high levels of insulin in the system, it just cannot work and blood sugar stays high. So that's the essential difference between these two. Now, types of diabetes, there's a secondary diabetes also, which is as a consequence from another disease. For example, if you get pancreatitis because of high lipids or high triglycerides, or cystic fibrosis, where the pancreatic ducts are all plugged up with very thick secretions, and you end up burning up the pancreas. As a result, your beta cells don't function well, and you get diabetes because of that. There's also a form of diabetes called gestational diabetes associated with pregnancy, because pregnancy, as we know, is a highly steroidogenic state. There's a lot of growth factors involved. There's a fetus growing inside the female's body. So that leads to a tremendous amount of stress on the insulin receptor, and as a result, the insulin produced may become dysfunctional and develop into hyperglycemia, which has got lots of connotations for the growing baby. The pregnancy itself may be threatened because of abortions and things like that, and the baby's growth may be retarded, or they may have premature births because of the same thing, and spinal problems. Impaired glucose tolerance is an intermediary between normal and diabetes. It's called diabetes in evolution or diabetes in disguise. So that is also another situation which we tend to diagnose quite early and then take necessary steps to remedy that. So a quick review of the anatomy of the pancreas. It's a gland that lies behind the stomach in the midriff area. There are clusters of cells inside the pancreas known as the islets of Langerhans, which produces 3 hormones, the islets with 3 types of cells, alpha, beta, and delta. Alpha produces glucagon. Glucagon raises sugar. Beta cells produce insulin. Insulin lowers sugar, and delta cells produce somatostatin, which is kind of a stabilizing hormone. It has got more functions to control other glandular secretions also. These cells have got special sensors that monitor the levels of blood sugar, and then that directs the release of the appropriate hormone. So we discussed this one. How does insulin work? A person normally secretes insulin in response to an elevated blood sugar level. It does this by accelerating blood sugar movement in and out of the cells, and cells will not allow blood sugar entry without insulin. So it is kind of a very simple way to look at that, but in actuality, what happens is when an insulin molecule binds to its receptor on the cell, it triggers lots of downstream enzymatic processes, which helps the assembly of the building blocks for receptors for glucose, and which will be extruded into the cell surface in the form of a receptor called Glut4, which binds glucose and internalizes the glucose. So that's how glucose gain entry into the cells. So if that process is not happening smoothly, then the sugar cannot enter the cells. Cells become deprived of energy, and then the glucose accumulates in the bloodstream, causing lots of hemodynamic changes. Why isn't the body making insulin? In people with type 1, the immunological system is the culprit. It attacks the beta cells, destroys them. In people with type 2, the pancreas is still making insulin, but just not enough to keep up. So type 1 is usually diagnosed in children and young adults. They must take daily insulin shots to stay alive. Type 1 accounts for 5 to 10% of the population with diabetes. Type 2 is a more commoner form of the disease. About 90% of the diabetics that we know belong to this group, where there is insulin production in the pancreas, but that is kind of a haphazard assembly of insulin, in the sense that it could be an incomplete insulin that is being released. So hence it doesn't have the shape and form to bind to the receptors, so it does not bind well, or the receptor themselves could be abnormal or coated with a substance called free fatty acids that we know now, and that can cause insulin resistance at a cellular level, and thereby the insulin is rendered without any function. So it's nearing epidemic proportions because of increase in people who are living in their old age, and as well as because of sedentary lifestyles, change of diets, etc. So gestational diabetics I mentioned to a little while ago regarding pregnant women with higher growth factors because of a growing fetus, and their receptors becoming a little bit hyper resistant towards the insulin and other growth factors. And so a woman tends to develop hyperglycemia very quickly. And if that blood sugar crosses the placenta, then that higher sugar level inside the baby's blood can trigger the baby's pancreas or tax the baby's pancreas to produce a lot more insulin and eventually tire the baby's pancreas out. And when there is excessive insulin being produced in the baby's body, the baby's tissues tend to get more hypertrophied, and that leads to increase in birth weight and causing problems during childbirth. So what are the symptoms of diabetes? The polyphagia is produced because of higher insulin levels, and sometimes those insulin levels crossing over into the brain, producing a condition called neuroglycopenia, whereby the brain is deprived of sugar because of higher insulin levels. And so this can trigger the eating center or the appetite center to excessive eating and delayed satiety. So thereby they stretch their stomach linings out. So that is called polyphagia. Polyuria is excessive urination because the kidneys threshold for retaining sugar is about 180. And once it crosses that, then the kidneys will tend to release the sugar through the urine and drags a lot of water or body fluids with it, which leads to excessive urination, which in turn triggers a thirst mechanism. So you tend to intake a lot of fluids. So there is blurred vision because the lens is getting saturated with the sugar, and that will change the focus. So you get blurred vision. Typically, people describe it as looking through water, and there will be poor wound healing, irritable moods, because it depends upon the brain's blood sugar levels. If there is hyperinsulinemia and that is crossing over to the brain and producing neuroglycopenia, patient gets irritable moods. A lot of obese kids, this has been misdiagnosed as ADD or ADHD. So that is something which we have to closely focus on advice. Recently, I saw a patient who had seizures, which was intractable, and brain scans were normal. Patient did not have any abnormal vasculature. Blood pressure was very well controlled. And when we did a fasting insulin on that patient, it came very high, and typically this patient was neuroglycopenic, and the brain sugars were typically around the 20 to 30 range, even though it has not been able to be diagnosed. But that's what we have found in horses and other animals, where we were able to install small electrodes in their brains, so that causes irritability of the brain. It also is linked with an increasing incidence of dementia in people that we see. Of course, the big harbinger for that is frequent hypoglycemia of the brain. So which is another reason why when we advise diets and insulins and all that, our first focus should be to avoid hypoglycemia. Fatigue and pain, tingling and numbness, hands of the feet because of neuropathy. Now, how do you diagnose? Normal fasting blood sugar is less than 110. Impaired fasting glucose is more than 100 to 126 milligrams. And empirically, it has been set, the level has been set at 126 or above for the provisional diagnosis of diabetes, for the simple reason that a lot more patients will be unnecessarily diagnosed with diabetes, can cause a lot of significant emotional and physical stress because of that. So you need to have at least 2 readings, fasting sugar more than 126, or a postprandial sugar of more than 200 milligrams percent, and A1C levels are also now known to be corroborative. So, and the A1C cutoff vary from lab to lab. Diagnosis, in order to be diagnosed with diabetes, you should have symptoms of diabetes. Your plasma glucose fasting state should be fasting should be more than 126, and postprandial should be more than 200, and a 2-hour plasma glucose should be more than 200 on an oral glucose tolerance test, which I personally don't favor, because that's not a real life indication, because we don't drink glucose water as part of a meal, and glucose is preferentially absorbed quickly in some even normal individuals can give you abnormal readings. So who is at risk? ADA now recommends that screening for diabetes should be considered for all patients at age 45. If the results are normal, it should be repeated every 3 years. And screening should be considered at the younger age if the patient meets risk factors of obesity, first-degree relatives of diabetes. They belong to a high-risk ethnic group. They were diagnosed with gestational diabetes or delivered a baby whose birth weight is more than 9 pounds and hypertension. So again, this is the classic metabolic syndrome where you find HDL levels less than 35 or triglycerides more than 250. Patients seem to have impaired glucose tolerance where the blood sugars are fasting. They run about 120s and waistline over 40 inches in men and metabolic syndrome. So assuming that you've diagnosed a patient with diabetes using these criteria, now what do you do? So a big aspect is education. I would say more than 50% of the diagnosis after the diagnosis of diabetes, the emphasis is on education, education, education. A diabetic diet is no different from anybody else's, but they must keep track of what they eat, not just the carbs. So previously there was a lot of emphasis on carb counting, but now we have realized that there are other food groups also which can affect insulin sensitivity, especially fats and the type of proteins that we use. So typically we advise lean proteins like fish, chicken, turkey, pork, and eggs, and less amount of red meat and less amount of processed meat like salamis and sausages and things like that, which may contain a lot more higher fat components like fats and brain and things like that. A food diary is a great start, and patients need to understand and see and know what that particular food contains, especially if you're dealing with diabetes. And serving sizes must be emphasized. Treatment goals for type 1 is to match insulin to food intake. So type 1s are encouraged to be precise and regular from day to day with food intake, insulin regimen, activity. It goes the same for type 2s also. And exercise and diabetes, exercise will definitely increase the flexibility, muscle strength, and well-being. They are advised to monitor their insulin food intake to match that exercise. I typically advise patients to consume a small snack before exercise so that you're not taxing the body unnecessarily, and which increases insulin effectiveness and sensitivity. You're basically enhancing the binding effect of insulin on peripheral tissues. This is designed also in such a way as to achieve normal or near normal blood sugar levels and fluctuations, provide adequate calories for reasonable body weight, and prevent or delay or treat nutrition-related complications and improve health through optimal nutrition. So exercise is especially beneficial in type 2 diabetes also. It promotes weight loss, increases insulin sensitivity, reduces the demand for insulin. Must also be aware of medications and other modalities of care so as to prevent hypoglycemia. So typically I tell when I design diets for patients, I usually include a snack at 10 o'clock in the morning, at 3 o'clock in the afternoon, and at bedtime. This is to avoid hypoglycemia in case there is a buildup of insulin in their system. So optimal use of snacks, again, to be adjusted according to their blood sugar fluctuations. And carbohydrates are the component of food that causes an increase in blood sugar, especially unopposed carbohydrates. So typically we tend to avoid simple carbohydrates and concentrated sugars for the same reason, and also give more emphasis to complex carbohydrates, and usually marry that with an element of lean protein. So it kind of balances everything out. So diabetics are encouraged to keep track of the amount of carbohydrate they eat and match the carbs to good quality protein, like lean protein that we discussed, and control the fat intake. Again, fat, we now know that free fatty acids are one of the factors that control the efficiency of the insulin receptor. So as much as we can, if we can control saturated fat intake, this can limit the amount of free fatty acids and glycerol, which can affect receptor function. So methods of carbohydrate control, there are many new methods of controlling diabetes, but these are still the two most common, which are exchange lists and carb counting, very basics, and allows a little more freedom and variety with that. But we are slowly moving towards the insulin-centric theory, where we should make sure that whatever we do, the insulin is effective. And we have identified certain factors like free fatty acids, saturated fats, things like that, which can block insulin. So we have moved away from advising people with fried foods and red meat intake, things like that. So we have been stressing a lot more for less saturated fat intake. All diabetics must keep track of blood glucose levels by glucose monitoring. This is the only way to know if your treatment is effective, and also gives pointers as to which way the blood sugar is heading, whether it's good control versus poor control, suboptimal control. So nowadays we've got the sensors, which gives us a better idea as to the fluctuations of blood sugars, and especially gives rise to the idea that whether a particular food has been effective and how it has been working. They can virtually map a certain meal and find out how the meal did for them. If we can repeatedly show them that how the blood sugar fluctuations are, it might even motivate them to stay away from high glycemic index or high blood sugar fluctuations inducing diets. One classic example is burgers and Coke. So if somebody can wear a sensor and then show to them how those fluctuations are, typically sensors give you about 20,000 readings a week, which is a lot of readings, which gives us kind of graphic details of how blood sugars fluctuate. So this gives them also the feedback which they require, so to know their bodies better. And also we must check, at least if you're manually testing it, at least 2 times a day for well-controlled diabetics, to about 4 to 6 times a day for very fluctuant diabetics, and also people who are using multiple daily doses of insulin. A1C is a good indicator of blood sugar control, gives us a percentage number that indicates control over the preceding 2-3 months. Again, there are caveats in this one. If the patient is anemic and the turnover of hemoglobin A1C is rapid, then their A1C may not get enough exposure to glycemic fluctuations. So you might get a closer to normal level, which may not mean anything. Also, if you get an abnormal hemoglobin in their system, so which is why there is something called a factor called total glycohemoglobin, which you can sometimes ask for, or sometimes fructosamine level, which gives you an average of about a week as opposed to 3 months. So if you don't expect a certain A1C in a certain range, if you suspect that A1C reading may be erratic, you can ask for these tests. It is usually performed about 2 to 3 times a year. About once every 3 months is what we typically order. Hemoglobin A1C of 6%, in most labs indicates good control, and a level of more than 8% indicates action is needed. Dietary guidelines, which we advise patients, is eat a diet low in saturated and total fat, eat a diet which is moderate in sodium and sugar, eat 5 or more fruits and vegetables a day servings, and also choose a diet rich in whole grains and lean protein, and moderate use of alcohol, means no more than 30 grams. Eat at the same time every day, at least within an hour of regular times, not to leave too many gaps. And these days, the concept of intermittent fasting has become very popular, very effective. So I tell patients to eat their dinners roughly about 5 o'clock or no later than 6 p.m. and then eat their breakfast the next day at about 8 o'clock. So we typically get about 14 hours to 15 hours gap, which is considered kind of an intermittent fasting. So you limit the amount of caloric intake. We give more time for digestion and settling down on blood sugar levels, and also give more processing time for insulin. And also eat about the same amount of carbohydrate with each meal, preferably, and also choose the type of protein also, like we discussed before. So other treatments, type 1 and type 2, patients need to be treated with insulin, and there are more than about 20 types. They differ in about how they are made, how their chemical consistencies are, how they work in their body, their affinity to the receptor, and their cost. So usually short-acting insulins like Humalog, Novolog, insulin aspart, insulin lispro, glulisine, those kind of insulins, they all have a pretty much a similar type of half-life. They have a sudden quick buildup of peak in about half an hour, and they are present in the blood and active on the receptor roughly about 2 to 3 hours, and then they disappear. So typically they're good to cover a meal. So mealtime or boluses, they would do a good job, but some patients where they're eating mixed meals, and if there's too much fat in that meal, and they've got underlying gastroparesis, and they take about roughly 3 to 5 hours to digest that meal, then that short-acting insulin may not be, maybe too short for them. So it might be getting out of the system before that meal's glycemic effect is completely passed. So you end up with hyperglycemia. So in that scenario, I tend to use something called 70-30 premix, which has got 70% long-acting and 30% short-acting insulin, which kind of gives you a half-life of roughly about 5 hours. So as opposed to 2 hours, we get an insulin effect persisting about 5 hours, so which gives us a little bit better way of managing their glycemic excursions. But the caveat is that it can produce hypoglycemia more often, so which is why I typically advise patients 3 main meals and snack at 10 o'clock in the morning, 3 o'clock in the afternoon, and at bedtime. So if patients adhere to that regimen, then we get a much better and easier conversion. It's known as the poor man's pump. They differ in how they are made. Like I mentioned before, variable regimens are available, but basal bolus regimens are more physiologic. So by meaning basal regimen, we typically put them on glargine or detamere or levemir at bedtime, and along with a small snack, because they all tend to build up to a peak and it's around about midnight, about 1 o'clock or so. So to avoid hypoglycemia there, if you give it to them along with the bedtime snack, it'll avoid that hypoglycemia. So oral medications are several different classes are available. They're used to treat type 2 diabetics most of the time, even though GLP-1 or DPP-4 medications are sometimes indicated for type 1s also. So we use the sulfonylurea or the glenides, which are basically secretagogues. They stimulate the pancreas or beta cells to make more insulin. So when you look at the timeline of type 2 diabetics, they spend about 10 to 15 years in impaired glucose tolerance / hyperinsulinemia phase, where the beta cells work overtime. Sometimes they hypertrophy also. And then by the time you diagnose them with type 2 diabetes, they've exhausted about 50% of the pancreas through this prolonged phase of hyperinsulinism, and eventually they're on a decline phase. So when you diagnose them, they've lost about 50% of the pancreas, and then the other 50% we should need to protect rather than whip them to death. So ideally speaking, I have stopped using sulfonylurea and glenides completely because of this reason, because you're only accelerating the failure of the rest of the beta cells. And plus, we now know that the hyperinsulinism can cross the brain and produce neuroglycopenia, forgetfulness, accelerate dementia, things like that. So, and also hyperinsulinism is a growth factor, so it can promote growth. You've seen skin tags grow in many people's necks and armpits and all that, which is a classic example of hyperinsulinism and growth factor accentuation. So since it may have some physical and molecular characteristics of triggering new cell growth or new cell growth, it could be linked with even cancer formation. So in fact, the other rogue receptors in cancer has been known to bind extra insulin. So which is why insulin may have a mitotic effect on cell growth. So which is another reason why we tend to lower the need for insulin. This is a paper which came out not too long ago. When was this? This was published end of 2020. It says too much of insulin is not a good thing. So this gives a lot of insights into as to how insulin could be activating certain abnormal cell growth patterns. So which is another reason why I tend to dissuade people from using sulfonylurea and glenides. Metformin, on the other hand, lowers blood sugar by reducing glucose from the liver during night, so which might be a useful thing. It also hinders the absorption of calories to the gut, so you can basically help people lower their body weight by using this. Again, metformin, the dose response curves, if you follow them, there's not much of significant dose response relationship once you cross 1,000 milligrams. So if somebody's on 1,000 milligrams once a day, and if you bump it to BID and give them 2,000 milligrams, you probably are not getting much benefit out of the escalated dose. However, you may also be aggravating their stomach discomfort, especially if somebody is gastroparetic. You can enhance more gassiness of that stomach and produce nausea or abdominal cramping or irregular bowel function by escalating the dose of metformin. And also, if their renal function is not that great, they are teetering towards stage 2 or stage 3 renal dysfunction or chronic renal failure, I tend to take people off of the metformin or reduce the dose down to about 500 milligrams once a day, as opposed to 2,000 milligrams daily. Now, Clt2 inhibitors are the new type of kids on the block, so to speak. They've been around for about the past 2 to 3 years now. The protagonist was Invokana or canagliflozin, and then subsequently we have had Jardiance, empagliflozin, and we also have other similar agents there. And there has been the Impaired trial, which came out a year ago or a year and a half ago, where it was shown to improve cardiac toxicity in diabetes. So the major advanced endpoints in those studies were all benefited because of use, because basically the way this works is it helps excrete glucose via urine. So whatever drug that enhances glucose disposal or gets rid of it from the bloodstream will improve vascular biology. That is the basic principle. So if you use insulin appropriately, if you put them to activity, exercise, and then burn off those calories quickly or dump them in the muscles quickly, whatever way you're enhancing the clearance of glucose, you're going to improve vascular biology, help the heart. So which is why I tend to use that principle in my patients, ask them to exercise a little bit immediately after the meal, go for a walk, a relaxing walk, nothing like a major jog or those kind of things, which could be counterproductive, which can increase the stress on the heart. So that's how the SGLT2s work. So again, these receptors are present in the kidney tubules, where they modulate reabsorption of the sugar, which is filtered at the glomerulus and puts it back in the blood. Instead of that, if you block that receptor, you tend to not to reabsorb that sugar. It goes as glycosuria in the urine, and which is another reason why if you see sugar coming out in the urinary passages, then those patients may have an increased risk for a UTI. So we have to be careful about that. So I tell patients, this is a side effect. You can lose some weight, you can improve your blood sugars, but if you're going to get more than 3 UTIs in a year, you have to use more antibiotics, which might affect the microbiome inside the gut, which is another can of worms, which we are opening if we change that microbiome far too often. So that's where I draw the line. If they get more than 3 UTIs a year because of SGLT2s, I tend to take them off of it. So other medications, thiazolidinediones, this is a very important medication, which unfortunately has not been utilized much because of the data that came out initially when in the days of Avandia or rosiglitazone. This was making big headlines. Pretty much every diabetic was going to use that, and it was found to benefit the insulin receptor. So the insulin use came down. There was significant improvement in those patients, and pretty much everybody was having a stable blood sugar outcomes. But unfortunately, some patients, went by the usual routine. If 1 tablet does not work well, go for 2 tablets. If 2 tablets doesn't work well, go for 4 tablets. So when you escalated the dose like that, then you ask for trouble. So unfortunately, just like the metformin example I gave you, the thiazolidinediones produces a lot of water retention, so swelling of the ankles, and that proved to be a risk factor for congestive heart failure. And these patients had more cardiac morbidity. So this led to a revision of the guidelines. And so eventually thiazolidinediones went out of favor. So in that scenario, pioglitazone came up, and pioglitazone was found to produce less of vascular tension and improved vascular biology. So for a while, they were the kids on the block. And eventually, somebody pointed out that, okay, patients are getting more bladder cancer and also more heart failure because when they used 15 milligrams, it worked well, but if sugar wasn't controlled well, the 15 milligrams became 30 milligrams, and then eventually 45 milligrams, sometimes even 60 milligrams. So when you increase doses like that, then again, trouble set in. So too much of a good thing is bad. So then all of a sudden they start having weight gain, fluid retention, and subsequently heart problems, and the bladder cancer issue came up. But then since then, for the past 10 years, those issues have been dealt with, and the data has been collected over long term, and more patients have been studied, and we now know that bladder cancer is part and parcel of diabetes. Part and parcel of getting older. So all of these factors, thiazolidinediones, in fact, when they compared patients with bladder cancer and using thiazolidinediones, they found that the people with diabetes, the incidence of bladder cancer was about 10%, and people taking thiazolidinediones, the incidence was 2%. So in effect, you can postulate that it actually reduced the incidence of cancer, which is what thiazolidinediones have been known to do in other cancers too. We use it as an adjuvant in a lot of cell multiplication theories, and we have found that it helps in psoriasis management, where there is piling up of cells on the skin. We've utilized thiazolidinediones as an adjunct in multiple myelomas and also in metastatic melanomas, where it can sometimes reduce hyperinsulinism, because one of the treatments for metastatic melanomas is our medications like sorafenib, which can produce hyperinsulinism and can aggravate diabetes, whereas if you use thiazolidinediones, it counteracts that and corrects the hyperinsulinism and may help to mitigate the bad effects of hyperinsulinism. So I utilize this medication. It is cheap. It is very effective. If you use, as a rule, I don't go more than 15 milligrams once a day. So that way we don't have the risk of water retention. We don't have the risk of weight gain. So you can safely use that. In fact, I use that in a lot of metabolic syndrome, pre-diabetic, impaired glucose tolerance, hyperinsulinemic patients, where you can protect the brain from the brain fogginess or neuroglycopenia. And there was a few studies done in the 80s on such agents where it was thought to improve brain function in elderly diabetics. So a lot of nursing home patients got put on that medication, and they found that, in fact, the brain memory scores improved. But however, nursing home patients over age 80 have to die from something. And of course, when they died, of course, the people were too quick to point out that probably they died because of the use of thiazolidinedione. So, which is again a point which was taken out of context, and it was the idea was misinterpreted, or the data was misinterpreted, and that is why a lot of physicians lost confidence. So I would encourage you to use the thiazolidinedione 15 milligrams once a day. It's very inexpensive. It's very excellent. And this is the only medication now available which can improve insulin sensitivity at the receptor level. So that is what improves insulin action. And like I said, again, using too much insulin is not a good thing, because it'll bind to other receptors and produce even mitotic changes in the cells. So and also accelerated aging. Thiazolidinedione has been shown to lower all kinds of markers. We have also lots of other data which suggests that it even improves renal function at every renal threshold level. So overall, it's a great medication to use in type 2 diabetics. Alpha glucosidase inhibitors, they slow the process of carbohydrate digestion. DPP-4 inhibitors reduces glucagon production after meals and enhances insulin. But DPP-4 is dependent upon your resident GLP-1 level. If your GLP-1 level is low, it's not going to work. So that's why instead of using Januvia and those kind of things, I would use GLP-1 agonists. So there is an oral GLP-1 and injectable GLP-1. The oral one is called semaglutide 3 milligrams or Rybelsus, which is a tablet which attaches itself to the stomach and releases the hormone locally, and it kind of does its effect. So it improves, it potentiates insulin, lowers glucagon, so thereby postprandial glycemic excursions can be effective. GLP-1 agonists are used to improve insulin potency as well as suppress glucagon post meals. Exenatide, Byetta, Lexacenatide, liraglutide, dulaglutide. The most important effects are the GI, basically, because it can paralyze the stomach and aggravate your gastroparesis in a patient, so they can have retention of food. And by reducing the amount of food emptying into the intestine, that's how it produces a reduction in glycemic pattern, improves satiety, and may help weight loss. So, which is why typically with Ozempic, I've seen up to about 20 pounds weight loss in about 3 months period. So, of course, we need to titrate it carefully. So, talk on GLP-1 is itself a different talk. So, then there is inhaled insulins available, which is called Exubera and Afrezza. Exubera was the first one that came out. Did not survive the market because we were using a lot more insulin. It was causing a lot of growth effects inside the lungs. So the lung membranes got thicker. If they had COPD, that got aggravated. So we had to monitor the pulmonary function testing. We still have to do it. But then came out Afrezza, which is a much more convenient way of using insulin, inhaled insulin. It comes in a convenient inhaler like this. Can you see this? So it is very convenient. You just have to pop in one of the cartridges inside and then close it and then inhale that. So instead of people who are needle phobic can use this because there's no needles involved, it's just an inhaler. And publicly, it doesn't produce any upsets for patients, and need to monitor pulmonary function tests, of course. And we must prove insulin failure to be able to use this medication because it's still expensive. So treatment goals, our main goal is to normalize blood sugar. Realistic goals are 70 to 140 milligrams before meals and less than 180 after a meal, and A1C within 1% of normal, which is roughly about 7% arbitrarily. So we need good blood sugar control to avoid complications. Complications are blindness caused by retinopathy, kidney disease with nephropathy, heart disease and stroke, and nerve disease, amputations, etc. How to avoid complications: control your weight, eat a healthy, well-balanced diet, get regular exercise, have regular checkups, check your feet every day for cuts and blisters, use protective footwear, do not smoke, and keep the blood sugars controlled. Avoid 2 common diabetic problems of hypoglycemia and hyperglycemia. And that is all I have. Diabetes is a very complicated disease if you let it control you. But if you control it, you can live a normal life and be proactive, not reactive. And I thank you for your attention.
Thank you so much, Mr. Sunil. That was wonderful. If there are any questions, please unmute yourself. I see that we have one person here to ask. We did have Dr. Robert Bernstein join for a minute, and he's been pulled into some other things, so I'm going to send him your PowerPoint as a follow-up.
All right.
That was really comprehensive. I'm excited to see that there's an inhaler for insulin.
Yes.
I'm sort of needle phobic, so fortunately I don't have diabetes, but
right.
That would be a wonderful thing for a lot of people like me.
Right. Yeah, so previously we had this very complicated, big, heavy, like a thermos flask it used to look like. So it was a little bit difficult on the patient standpoint to use it, take it around and all that. But now this has become very, very convenient for them to handle, put them in their pocket. In fact, we ask people to even carry something like an Altoids box where it can control, which can hold this one as well as 3 or 4 cartridges inside.
Oh, that's a great idea. Yeah.
Yep.
And then the screenings, that just was announced, right? That 45 years and older is the recommended screening age.
Correct.
Yeah.
Correct. Yep. So in fact, we are a little bit more proactive than that, because if at all, if I get somebody with polycystic ovarian disease or just garden variety obesity, I usually tend to check their fasting insulin level, and you'll be surprised. I've got one laboratory result sitting here in front of me, which came back as 67 units of insulin, which was fasting insulin. So if you're waking up with the body with no food in your stomach, with the level of 67, imagine what your pancreas is going to do after they sees the first bite of food. So this is something that patient did not have symptoms, but when I asked for the neuroglycopenic symptoms, forgetfulness, this patient was 13 years old. Forgetfulness and gassiness, uncontrollable appetite, everything. They said I would have eaten 2 sandwiches in one sitting, and then within 2 hours I'm hungry for more. So, we are seeing a lot of obesity because of this, because of undiagnosed hyperinsulinemia.
So this is not related at all, but I just wanted to share that California Care Force will be holding a clinic in Chico. They were last here in 2019. And of course, they couldn't do clinics in 2020 because of the pandemic, but they'll be here in November. And the reason I mention that is because my husband's a physician who volunteered in 2019. And he was able to help a patient who had diabetes for 5 years, but didn't know. So the California Care Force just opens its doors for vision, medical, and dental care, regardless of insurance status. So it's very helpful for our community. And I just remember that my husband was able to diagnose somebody who had not had any sort of treatment for 5 years for diabetes, which, as you know, is really problematic. So
Right.
I'm going to be recruiting physicians to help with California Care Force in November, if we still can do that clinic in person, given the COVID-19 stuff that's surging again. So
Absolutely. That's a great thing that you're doing, and count me in, and I can help if you need me.
Oh, fantastic. I'll be sure to email you their information. You have to sort of enroll in it and
Right.
all that stuff. So, but it's a wonderful clinic. It's amazing how many people let dental care and their eyesight and vision problems go on, and as well, medical issues, undiagnosed, untreated, and potentially that much more challenging. So I'm gonna, it doesn't look like we have any questions, and I'm gonna wrap up and say thank you again for doing this.
Yep.
I'll be putting together the 2022 schedule for our virtual grand rounds soon, and look to you for your ideas. We can do one again, and this will be recorded and then posted on our Butte-Glenn Medical Society YouTube channel, and then I can share that with everybody. So.
Okay. Sounds good.
All right. Well, thank you so much, and we'll see you soon.
Thank you, Christy. I appreciate all your help. Bye-bye.
Bye-bye.